This week on the BackTable podcast.
We found that if we can stain the lesion ahead of time, it makes our procedure much faster and also much more accurate because, as you know, when you put a probe in, it also causes streak artifact if you're using it under CT. So you can also obviously use ultrasound guidance, which I would say probably outside the United States, most practitioners use. But the combination of ultrasound, CT, especially with staining, I think really has helped us to accurately place probes.
Welcome to the BackTable podcast, your source for all things interventional and endovascular. You can find all previous episodes of our podcast on iTunes, Spotify, and on backtable.com.
Welcome, everybody. Thanks for joining and tuning in to BackTable podcast today. It's supported by an educational grant from Varian. And I have with me a special guest, Ed Kim, Director of Interventional Oncology for Mount Sinai Hospital, and a true pioneer in the interventional oncology space. And I'm Kavi Krishnasamy, an interventional radiologist, interventional oncologist at University of Alabama, Birmingham. Ed, thanks for being here. True honor. Love to get into this topic today. Very excited to chat with you. And again, thanks for being here.
Hey, thanks, Kavi. Just thanks for having me on the podcast. Super excited to just talk shop.
Always a pleasure. And our topic today will be microwave ablation and the algorithm for treating HCC, technical tips and tricks for the intervention. So Ed, without further ado, where does microwave ablation fit into your algorithm? How do you choose in this day and age between microwave ablation and something like radiation segmentectomy?
Yeah, so I would say that, it depends on the disease state that you're treating. I think first and foremost, patient selection is important. When it comes to selecting patients that could have potentially the best possible outcomes with microwave ablation in particular. So for us, we kind of divided up into patients with HCC and metastatic disease. Let's tackle the HCC aspect of it. There's very robust data in support of thermal ablation, and I think microwave ablation is on the spectrum of heat-based modalities like radiofrequency ablation. And when we look at those technologies, there's a wealth of data. I would feel comfortable saying there's thousands of studies that have been published over decades in support of thermal ablation and microwave ablation. In those patients, I think the data strongly supports very early and early stage for lesions up to 3 centimeters in size. And that is what our practice also supports. If it's in a good location and it's about 3 centimeters in size for HCC, we will actually go ablation first, despite all of the Y90 radiation segment data that we have published. Where it falls in the spectrum in those stages of whether we choose microwave ablation or radiation segmentectomy depends, number one, on location. If it's in a difficult location, this has been well published from multiple key opinion leaders in terms of suboptimal locations for ablation, whether it's near the hilum or near pieces of bowel or critical structure or potential heat sinks. We strongly support that as well. And so we try and keep ourselves out of trouble. And if it's a hypervascular lesion, we tend to go radiation segmentectomy for those types of lesions. But let's say you're in a segment 5 or 6, the lesion is 3 centimeters or less, there's no critical structures, there's no heat sink nearby. Then I think the literature supports doing an ablation in that type of setting. And we'll probably go into various studies that support that as well. We have prospective data supporting that over or equivalent to surgery. I think other factors that come into play that are hypovascular lesions you get once in a while that are HCC for whatever reason, they aren't hypervascular, then we'll tend to gravitate towards ablation in that type of situation as long as we deem that it's safe. We may be pushing the boundaries a bit, but we'll push for ablation in that type of setting. So, that's where we are with HCC, and certainly we can talk further in terms of metastatic and palliative settings.
That's great. That's a very well-developed algorithm. I think when you look around the country, it seems a little bit less standardized. Would you agree, disagree with that statement? Or I guess the better question is, how do we come together as an IR community and try to standardize some of these algorithms, as you already alluded to?
Yeah, I think it's not such an easy question to answer. For instance, in our institution, we're an extremely high volume HCC center. We have a transplant program. We have an NCCN designated liver cancer program. And so, we're running a practice that has been an iterative practice over probably 2 decades now. And so we've stayed consistent with those algorithms as you've stated. But when you go across, even within the United States, let's say, to keep things simple instead of a global perspective, it can be quite difficult. The experience with various technologies will be heterogeneous. Again, we have crafted our experience with radiation segmentectomy. We've published on it, as well as our experience with ablation. But in certain centers, they may just be starting their experience, let's say, with a radiation segmentectomy. And so they may feel more comfortable in pushing the boundaries of ablation. And in other centers, they may be key opinion leaders when it comes to ablation, using various methods and technologies to really push the boundaries of what has been published. And I think that's okay, as long as that's within your comfort zone. And first and foremost, as long as patient safety and outcomes are optimized with your experience, I think that's okay. And I think we're going to also go into various technologies later on, probably in this podcast. But, there are also emerging technologies which groups may be getting more experienced with. And so that will certainly affect practice pattern as well. And not to mention, within the institution, it's also who you're working with. So, our referral patterns and multidisciplinary collaboration may be quite different from another institution. We're strongly allianced with our liver transplant team and our surgeons, along with our medical oncologist, as well as other services. But maybe at another institution, there's more of a stronger alliance with medical oncology and a stronger influence. And so that could also affect certain types of practice patterns. So I wish we could create this kind of one-size-fits-all algorithm, similar to how, let's say, medical oncologists practice with the NCCN guidelines. But we all know that medicine is not like that. Medicine, that's when we talk about the art of medicine. And so I think it has to be based on your institutional preferences. But I will preface that by saying there are guidelines in place, and everyone should be ideally working within a multidisciplinary team. And I think those have shown to really improve best outcomes.
Yeah, it's a great point, and you're right. It's different. It is different everywhere. It's different for me at UAB as well. And for us, we have transplant surgery, medical oncology, radiation oncology, and interventional oncology. And I think as you already alluded to, identifying the right personalized plan, or the optimized personalized plan for an individual patient, the individual tumor, based on the characteristics of that lesion, is optimal. So it's a great point. And Ed, you already alluded to this kind of suboptimal locations. There was now that I found out your alma mater's Rutgers, actually, there was a recent Rutgers paper, as you already alluded to, amongst other literature, on suboptimal locations, pericholecystic lesions, subcapsular lesions, dome lesions, central lesions. How aggressive do you get with dome lesions? There's the Fred Lee's paper from several years ago talking about ablation near the diaphragm and not having a lot of untoward consequences. Are those lesions that you'll tend to go after with an ablation probe? How about the subcapsular lesions? How aggressive are you in those situations?
Yeah, I'll just say that I was at a recent conference, and a surgeon had actually presented some data demonstrating that there was equivalence for ablation versus surgery. And he was fully in support of this. He also said, with a disclaimer, that the authors in papers are not universal. And I think the key, and we'll probably get into this later in the podcast, is to try and homogenize so that individuals who are doing maybe a handful of ablations on an annual basis versus individuals who are doing hundreds of ablations on an annual basis can achieve similar outcomes. And we know that this is not true. So I'll open with that to say that in our practice, we do have lesions that can be at the dome or near other structures that we feel may not be optimal for, let's say, a radiation segmentectomy. We have to really assess, because even within our own group, there's heterogeneity of experience. And so if the individual feels with various technologies that we can do it safely and effectively, then we'll go after dome lesions. I personally have treated a lot of dome lesions with assistance from various technologies. But if you don't feel comfortable with it, I wouldn't advise it. For instance, the papers that you've quoted, those individuals do have a lot of experience and are vested in the space. But if you're not as experienced or you don't feel as comfortable, I wouldn't recommend going after that because there's also well-published papers citing that those lesions can lead to adverse events. And so I think one should pause, especially, for instance, Lavrahi has published a paper way back where showing that various locations do lead to higher adverse events. And that individual is quite respected in the field. So, I like to go to conferences as well and see, oh my God, these incredible things that people are doing. But I also like to look at the literature and say, what does the literature say? And if the majority of individuals will probably get adverse events from a certain location, et cetera, then I would tend to back off in those situations, especially when we have other technologies at our disposal. We can certainly use those or refer to other specialties.
Yeah, that's a great point. And even within, just saying something like a dome lesion, one dome lesion is not the same as another dome lesion, right? You could have an anterior segment A lesion that is very difficult to target, much more risky, and then, a posterior segment 7 lesion that you may easily see with the ultrasound and you can drive a probe right through it, right? So that's a great point. Do you have any no-touch lesions with ablation?
No touch. I would say that lesions abutting the hilum, for me, are no touch, because you could probably get away with ablating that with a decent outcome the majority of the time. But you think the minority of the time something can happen. And if you were to cause a catastrophic consequence from that, it's hard to defend. I would say another no touch is in individuals who've had previous resection with scarring and fibrosis of, let's say, bowel, especially something as fragile as colon, let's say abutting segment 5-6, and there's a lesion right there. That's a no-touch lesion for me, because that can lead to a catastrophic event of rupturing that colon. No matter how much dissection you do there, it's scarred tissue. It's not going to move away. So if anything, it's going to propagate the energy towards the bowel. So for me, those are no touch. The others, let's say high dome lesions maybe near the IVC or the heart, those, there are ways to treat those lesions with ablation, given the right amount of experience and technique. So I'm not going to say those are absolutely not, but the two locations that I've mentioned or situations that I've mentioned, for me, are no touch.
Yeah, that's a great point. I mean, and you already alluded to it. There's so much operator variability here, and kind of dependency on past experience. Even, for me, things like posterior segment 3 lesions. I know there have been techniques described on, putting hydrodissection fluid into the gastrohepatic ligament and successfully separating the stomach from the posterior aspect of the left liver. And I find that to be a challenging place to ablate a lesion and get adequate separation. So those are places where I tend to employ other therapies. But yeah, great points. So let's switch gears a little bit. How do you pick a device? Well, and I know we're going to try to stay a little bit device agnostic here, but how do you pick a device? What properties in the device are you looking for when you're either evaluating an ablation system or getting ready to put something on your shelf?
Yeah, so we've had, I think, the luxury of evaluating a lot of different devices and ultimately choosing one for our practice. And there are also a lot of new devices coming to market, or I wouldn't say a lot, but let's say new devices coming to market as well as updates on existing devices. But let's say we're just thinking about an ideal device that I would like to choose. For me, it would have to be keeping something at a single probe that generates a fairly large ablation zone. If you look at all of the data that we have thus far, 3 centimeter lesions, whether it's HCC or metastatic colorectal or other, metastatic disease processes, 3 cm is kind of the upper limit of where we see just outstanding results. Kind of my theory on that is that it's part tumor biology because it's still on a small kind of lesion. But I think it's also predicated on our existing technology. Most of the devices out there generate anywhere between a 4 and 5 cm ablation zone. For metastatic disease, you're aiming for 1 centimeter margins or more. And that's if you nail 3 cm lesions straight down the middle. For HCC, we have a little bit more room where it's 5 millimeter, again, straight down the middle for a 3 centimeter lesion. So it doesn't leave much left if you're using a single probe. And I think single probe is the most cost effective as well. I think in this present landscape where most healthcare centers and practices are looking at cost, I think that becomes a big factor, especially within our group. So, size of the ablation zone from a single probe as well as cost are important factors. I think another factor is in terms of where is your actual feed point on that probe. So, if it's 2-3 cms back, that means that potentially for a smaller lesion, you're sticking your needle out much further than you need be. And especially if we're talking those high dome lesions, well, that needle could now be sitting in the lung. And so a very short distance back for the feed point, or a feed point that stays steady, I think is important. And segue into that steady feed point, something that is predictable. Again, I understand there are various factors in play, heterogeneity of tumor tissue, heat sinks, location, etc. But if we could get a predictable ablation zone every single time, then some of the angst of creating a larger or a smaller zone than expected is taken out of the equation, and you feel very comfortable that, hey, this is reproducible, this is something that I can predict. And then, I don't want to go on forever about this, but I think another factor that's important is ablation software. Whether it's planning software to help you guide your placement of your probe or needle to the desired location, but for sure, I think we need confirmatory software post-ablation to show that we are indeed getting the margins that we need, if not the coverage of the tumor.
Yeah, that's a great point. I know we're all very excited to see some of the early acclaim results when they come out. I know that's colorectal focused and not HCC focused, but I think there are a lot of us in the ablation space that feel very strongly about that, just as you do. So it's great to hear you say that. What about things like needle gauge size? Do you ever get dissuaded by something like a 13 gauge microwave antenna, or do you actually value that size for the added steerability, things like that?
I think that, we're sticking to the liver here. So in the liver, for me, a gauge is actually not that important. Yeah, we're not talking like, something like 5 gauge here. That's ridiculous. But, whether it's, let's say, 13 gauge or 17 gauge, in the liver, I'm not as worried, to be quite honest. If we, I'm dating myself with this, but if we think back to the radiofrequency ablation days with certain probes, they were about 13 gauge in size. And we've never had any issues of bleeding, et cetera, complications with it. It's been well published. There's hundreds of papers published with radiofrequency ablation where the gauge size is about 13, 14 gauge in size. So for me, no, it's not an issue. For me, I prefer something that tends to be on a stiffer probe so that when I have to make the adjustments, I'm not fighting the tissue, especially cirrhotic patients, to try and get it to the angle that I need. For me, that's more important. And the sharpness of the tip of the probe, I think, is user preference. Some people like an extremely sharp tip, usually ceramic based, that can cut through tissue quite easily. I tend to be actually someone who likes kind of like a middle ground because I like the feel of the tissue when I'm pushing through. But again, that's just my preference.
Yeah, that's a great point. There's definitely a tactile feedback there if you value it, right? Absolutely. That's a great point. And we talked a little bit about some of the trials that have come out and are coming out, right? There's SURF. I know it's HCC focused, but focused on radiofrequency ablation. Collision is colorectal focused. Acclaim is also colorectal focused and focused on, and a little bit more targeted towards ablation margins. As this data matures, as this data comes out, how does it influence your practice? Or how should we as IRs be then taking this data to our tumor boards to help optimize some of these treatment plans?
Yeah, I think data is important. Guideline incorporation is important. Some of the data that you're referencing, for instance, collision, that was recently presented, hasn't, to my knowledge, been peer reviewed for publication yet, but it was presented, I believe, was it ASCO? Collision was presented, which is, obviously the largest oncology meeting, I think, in the world. And it's been well received. Just as a brief synopsis, we're looking at metastatic colorectal cancer. I believe the study was out of Netherlands, comparing ablation versus surgical resection and was stopped midway through the study because it demonstrated that it even extrapolated out that it has similar outcomes to surgical resection. And so if you can perform a percutaneous ablation with similar results, why would you go to resection is the question. And this has actually been endorsed by Society for Interventional Radiology as well with a statement. And so I think those, for instance, if you bring it to tumor board, helps. It's not the be all and end all, right? Because as you and I both know, when you go to tumor board, there's certainly more involved than just data presentation. You could throw data at everyone's face, but if you don't do it in a tactful manner, people aren't really going to care. So I think it's a part of building a practice at the tumor board and convincing others, but it's not the be all end all. And so I do think it helps. And certainly, again, inclusion into the NCCN guidelines also helps because that is a language that medical oncology and surgical oncology speak. So when you interface with different subspecialties, you have to understand what language they're speaking, right? If same as you go to another country, right? If you go to another country that doesn't speak English as their primary language and you start speaking to them in English, no one's going to understand you. So I think you have to understand what the language is. And then briefly going into the SURF trial, that was on HCC out of Japan for lesions up to 3 centimeters in size, a very similar kind of study, surgery versus ablation. Now, the interesting thing here is that all the investigators were either hepatologists or surgeons. And so there was no interventional radiology or radiology involved with this study. And so it's an interesting outcome, but it basically showed that ablation was equivalent to surgery in that, and that was published several years ago. And then we're awaiting the ACCLAIM study. And I like the ACCLAIM study because it is the only study sponsored by a society, SIO, and it's really looking at homogenizing that field. And this is where I think confirmatory software comes into place after you've done the ablation. You want to confirm immediately afterwards that you have enough margins and targeting of the tumor, because the devil is truly in the details. And so if you haven't, then you have to go back and re-ablate that lesion. And I think that is where we have to start getting into the mindset of homogenizing our field and our practice of ablation, because at that point, then potentially, whether you have a ton of experience with ablation or not as much experience, we're gravitating towards that homogeneity of the procedure.
Yeah, it's a great point, Ed. And it's I want to touch on something you said about tumor board as well. And so much of this, I mean, we can bring all the data we want to tumor board, but if we're not showing the outcomes as well, on the back end, if you will, and properly selecting those patients and those tumors, and not having those outcomes, then we kind of fall flat a little bit, right? So that's a great point. And I want to go back to ablation margin and ablation confirmation software. So clearly, you use ablation confirmation software. I assume you don't really eyeball any of these lesions, similar to the ACCLAIM trial, although we don't have that data out yet. And you feel this is valuable, as do I. But we're in a space where there's device-specific applications and there's device-agnostic applications. How do you choose, right? I mean, it seems to make sense that a device-specific application may be tuned to a specific device that you're using, but there are a lot of platforms out there. So how do you choose?
That's a very good question. In our institution, we have access to various technologies. And that's, I think part of that is with the relationships that we have built with industry over the years. But at most practice, I would assume that you're really going to have access to one or maybe two technologies for your ablation. So in terms of how we choose, we do have an existing platform that is device agnostic. And it's totally based on imaging where we can fuse or co-register pre and post imaging. And we found that early on, we used this technology starting 15 years ago. We found that it to be extremely helpful in terms of what we ablated and whether we had enough margins and tumor coverage, et cetera. Reconstructing 3D volumetric images, again, to show the margins in 3D, et cetera, and then inputting device specifications to see predicted how large the ablation zone will be and whether we have tumor coverage. All that was super important. And then we also have technology that is embedded, that is device specific and not agnostic, that is seamless integration, but it doesn't have the bells and whistles of our device agnostic imaging modality. And so this specific software just puts in the pre. You can't put historical cross-sectional imaging like PET-CT, MRI, etc. And it doesn't have any planning type of software per se. But I still find it extremely useful because afterwards we always try and get a post-contrast CT. We do the majority of our cases on a CT scanner in conjunction with ultrasound. And then that post-contrast CT superimposed or co-registered with our pre-CT helps us really to give us confidence that we have coverage of that tumor. Now, there are new technologies that are also coming out that potentially help you plan, and also with the confirmatory ablation software on the back end. So I think that'll be very useful, and that's device specific.
Yeah, and it's a great point. And it's a space that has come a long way, but I feel like it still has a ways to go, particularly in areas where you're planning a double probe ablation. To my knowledge, in my experience, I haven't seen a lot of ablation planning confirmation systems that are able to accurately kind of predict a dual probe or even a triple probe ablation and what kind of ablation zone you'll get. I don't know if there's something that you've seen that can do that, but that's one of those areas where we have a little bit of a ways to go, and hopefully we see something that's able to give us that in the future.
Yeah, for me, I think, for instance, there's an advantage if, let's say, an ablation device is tied to an imaging company as well that has access to the software, that has access to all the historical imaging, and then can utilize that in terms of planning and ablation confirmation. Because again, it gives you confidence that you've truly treated the tumor. And, we're talking about data sets and guidelines that are selecting best selected patients, optimal patients. But we all know that in practice, we're always pushing the boundaries as well. I wouldn't say not always pushing the boundaries, but we are pushing the boundaries in certain types of cases just because the patient may have no other option in terms of care. And so if we're pushing the boundaries there, I think even more so, we need planning and confirmatory software to show that we're getting adequate margins. And it most likely, for instance, for larger size lesions, take multiple probes, as you've mentioned, to achieve a adequate margin and outcome for that individual.
Yeah, it's a great point. And as you alluded to earlier, when you include cost in the scenario, moving a probe to multiple different spots around a lesion is not the easiest thing to do, right? I know some of us do it when cost is a concern, but it's an advanced level move, I guess, which I'm sure you guys do fairly frequently. So let's change gears a little bit as well. What about the manufacturer predicted ablation zone size? Is that something that you put a lot of stock into when you see that kind of on the printout or on the card, depending on the ablation system?
I wouldn't say that I put a lot of stock into it. It is ex vivo data for most manufacturers. Some manufacturers do have in vivo type of data, but we all know, if you've been doing this long enough, that it's quite unpredictable at times. We certainly, let's say a manufacturer says you're getting a 4x4 spherical ablation zone. It doesn't always work out like that. Again, various factors like cirrhotic tissue, heat sinks, heterogeneous tissue. Let's say there's a shunt within the tumor. That's also going to affect, let's say you embolized it beforehand, either chemoembolization or bland embolization beforehand. That's going to affect your ablation zone. But I do think the manufacturer's IFU does give us kind of some guidance, because we need some guidance, but I think for the advanced level of ablation individuals, that's where you can use time, power, reflected energy to really try and do more advanced maneuvers during the ablation. But I think that otherwise, the manufacturer's recommendations do help guide us. But you have to be, I think, wary of certain factors. For instance, I'm extremely cautious to perform ablation in individuals who have reduced portal inflow. So individuals with cavernous transformation, or individuals with a TIPS or with extreme portal hypertension, those types of individuals, you could potentially, from your ablation, clot off that whole portal vein. And that could potentially lead to a catastrophic outcome. And so you always have to be aware of the patient.
Yeah, it's a great point. And, kind of in that vein, do you feel there's relevance for real-time monitoring of that ablation zone? And I know we're not really there yet, but hopefully in our lifetimes or in our careers, will there be a platform where we can monitor in real time that ablation zone actively growing? What's that value to you as an interventional oncologist ablationist? And then how do you utilize something like that?
Yeah, I think that would be the ideal scenario to monitor in 3D. I'll kind of share ideally in what the optimal, for me anyway, real time would be. And that's to monitor your ablation zone three-dimensionally in a volume and to know the temperature on the margins. I think immediately surrounding your probe, it's going to be above 50 degrees Celsius, which causes irreversible coagulation. But what's it at the margins? I think that is the most important. Are we creating too big of a burn? Are we creating too small of a burn? And we want to, potentially add energy or time to that ablation. Varian's coming out with thermocouples that are along the probe length at varied distances. I think that will help us to kind of conceptualize what the ablation margin is going to be. Now, it's a single point in a three-dimensional ablation zone, but I think that is quite unique to it. There are other companies that are using ultrasound base to monitor the ablation zone kind of quote unquote real time. I'm a little skeptical because I've seen some of the tech, but I think your point about real time visualization of the margins and the ablation zone is spot on, because that will help prevent potential complications and also optimize the ablation zones. So yeah, when that day comes, I'm all for it.
Hopefully sooner than later, right?
Absolutely.
You mentioned that you typically get a contrast enhanced scan at the end of the case or the end of the intervention or end of the ablation. Is that standard for everybody in your practice? Is that what you tend to do yourself? And are there any situations where you won't do that?
I don't micromanage. So as long as everyone's outcomes are consistent with what the kind of standard of care is, I don't micromanage. So maybe people are doing post-contrast scans, maybe they're not. Me personally, yes. I try and do it on all of my patients if possible. But certain patients, it may not be the best idea to do an ablation. And the obvious question is, well, what are those patients? I think the easy answer is in individuals with kidney dysfunction, where you're giving too much contrast. Probably wait 4 weeks for them to we get a follow-up MRI if possible with contrast. If we needed to give contrast beforehand to visualize the lesion, and now we need to give more contrast on the back end to confirm, and the patient is borderline in terms of their kidney function, then those individuals, we'd probably pause and not give contrast. But outside of that, it's hard to, for me, cite a reason not to give contrast. At most, when you have everyone, your whole team, the technologists and the nursing team and anesthesiologists on board, it's going to add maybe 10 minutes at most extra to your procedure. And rarely do we go back in to re-intervene. But when we go back in, it's significant. It's because either technically we didn't hit the lesion as we had anticipated, or the device that you're using didn't get the ablation zone that you had anticipated. And so I think it's a practice-changing type of intervention. We all kind of use that rule. If it was our family member on the table, what would we do? Well, I wouldn't want, my family member leaving that table after they've undergone general anesthesia, et cetera, taking time off of work or whatever they're doing in their lives, and having someone drive them or paying someone to drive them to come back again for another re-intervention. So we try and do it all in one sitting if we can.
That's a great point. And I wholeheartely agree with you. I think in my practice, I'm almost, as you said, invariable with getting that post scan with contrast and then using that to determine, what I think my treatment zone is, and we have options, right? We are all comfortable with transcatheter and percutaneous interventions. So putting a microcatheter into segment 5 and giving a smaller dose of contrast and using cone beam CT instead of spiral CT, maybe those are options in some of these patients as well. But I'm glad you brought that up. I think that's a really important point that I've done for a long time as well. That's really important for this patient population. So speaking of lesions that can sometimes be difficult to target, are you ever staining lesions prior to ablation?
Yeah, our practice has actually gravitated in the setting of HCC, as well as hypervascular tumors from other metastatic disease processes to staining lesions if possible, especially difficult locations, or if we review the cross-sectional imaging, especially the CT, a non-con, and we feel that we're having a difficult time seeing it. We can certainly give contrast and use various software to mark the lesion, but we found that if we can stain the lesion ahead of time, it makes our procedure much faster and also much more accurate because, as you know, when you put a probe in, it also causes streak artifact if you're using it under CT. So you can also obviously use ultrasound guidance, which I would say probably outside the United States, most practitioners use. But the combination of ultrasound, CT, especially with staining, I think really has helped us to accurately place probes.
Yeah, that's a great point. And I'm a primary ultrasound user as well. I feel like from a targeting standpoint and alleviating some of that streak artifact in CT, it's helped me, and I can visualize the edge of the lung and make sure I don't, go through the edge of the lung and cause a small pneumo, something like that. So, but you're right. Most of, the world outside of the U.S., I think, is very ultrasound forward. I feel like we tend to be a little bit more CT forward in the U.S. I don't know if you concur with that or not, but we all have our comfortability when it comes to probe placement, right?
Yeah, I mean, in the United States, I can actually comfortably say that the majority of practice is CT based. And I think that's just our training pathway. I don't think we push ultrasound to the edge as much as places outside of the United States do. And that's because we do have the luxury. Well, if we can't see it, let's get a CT. If we can't see it on CT, let's get an MRI. And so there's no cap in terms of the amount of money spent on imaging modalities within the US. But for instance, in Europe or Asia, you have to really think hard and twice before you're ordering an MRI or even a CT. And so, I think that's where, for instance, there's a compromise made in terms of screening for HCC. There's a flip back and forth between ultrasound and CT. We all know that really the best way, if money's no object, is going to be screening with MRI. But it's cost prohibitive, especially outside the United States. And so I think we come to a compromise because cost is a big deal between ultrasound and CT. And going back to your question, I think that's why a lot of practitioners within the United States, we don't feel as comfortable with ultrasound because we're so quick to pull the trigger on cross-sectional modalities.
Yeah, that's a great point. Do you feel like our fellows that are, and I'm going to sidetrack a little bit, I apologize, but do you think our fellows are coming out with the ultrasound skills that they need? Or is it incumbent on them as individuals to kind of learn that as a junior IR?
I think that the simple answer is no. I don't think they have the requisite skills, for instance, as outside the United States in ultrasound to do procedures. I think, responsibility really lies within their attendings who are teaching them, right? And maybe those attendings don't have the requisite skills either. So it becomes kind of this vicious circle. But I think if you should always have an ultrasound probe and at least make an effort to try and localize the lesion, whether it's under CT or fluoroscopy or cone beam CT. And this is ablations along with biopsies, et cetera. Your skills will only get better. And then you do have the crutch with cross-sectional imaging.
Yeah, that's a great point. And I didn't mean to put you on the spot there. It's something I actually feel very strongly about as well. I like to tell my fellows that it's one of those skill sets that will really set them apart as an IR, is the ability to target lesions with ultrasound. So
absolutely.
I'm glad you said that. So what about some technical aspects of ablation? Do you hydrodissect often? If you're hydrodissecting, do you ever add contrast to your fluid to help with visualization?
I hydrodissect on occasion. And I'm very honest in public when I say that I'm not one of those advanced ablation individuals who are going to extremes like causing a iatrogenic pneumothorax to try and separate the lung from the lesion or putting in all these fancy dissection maneuvers with multiple probes. That's not me. I'm just a guy who evaluates a lesion to see if it's safe with a single probe for ablation. If not, it's other technologies that we've discussed in terms of radiation segmentectomy or other emerging technologies out there that could potentially treat the lesion. When I do hydrodissection, it tends to be in individuals that are in difficult types of locations that maybe the other technologies aren't necessary, and I could easily treat with an ablation. So, certain cases come to mind. For instance, this is going to sound actually funny, but I had a patient who was young, had a metastatic colorectal that was hypovascular. It was right on the capsule in segment 2, and it was right up against his rectus muscles. And this guy loved working out. So he had like an 8-pack, right? And that was very important to him. And so I didn't want to put a probe in there and potentially burn his rectus muscle, and then he'll, have kind of a non-symmetrical 6-pack or something. So in that type of situation, I'll put let's say a 20, all you need is a small needle, 21 gauge needle, and then we hydrodissect it. Usually I use D5W or something. I don't put contrast unless I feel that I can't distinguish some structures from one another. For instance, in the kidney, if there's a colon nearby, in that type of situation, I may use contrast because the water or whatnot may not help to distinguish and separate. So I'll use contrast in that type of setting. But in this type of setting, you just use a small gauge needle, and then you just start pouring in D5W or whatever medium that you want to use to separate. And then it'll create this plane of separation. Enough, you don't need much, but just enough to separate. And then again, based on what you estimate as manufacturer's recommendations, turn on the probe. I also use that to try and separate bowel if bowel is in the way. Usually colon, stomach is also, as we talked about earlier, one of those types of locations. But if it's not separating in the peritoneum, for instance, you have to put, as you know, a lot of fluid in there to really start to make a difference. You can also put air, but you have to be more patient, for instance, in the peritoneum. I don't cause an iatrogenic pneumothorax to push away lung. I haven't found the need to do that, but individuals do practice that as well.
Yeah, that's, those are great points as well. I mean, I had you can call it a luxury, you can call it not a luxury, but early in my career, when I was in a federal government hospital, I didn't have access to Y90. So I had no choice but to get super aggressive with some of my ablations. And, I had 4 needles, hydrodissecting from various spots. But as I look at my practice now, is that worth it? Is that 4 or 5 hour time commitment worth in the CT scan with the patient under anesthesia when I have other treatment options, as you alluded to? But there's so many other patient factors, like Alabama Medicaid doesn't cover Y90 for me. So those are patients where I'm going to ablate as opposed to, offer something else. So very, very, very good points. And that, as you talked about iatrogenic pneumothorax, that goes to pneumodissection using balloons and a lot of things like that. What about tract cautery? Do you do tract cautery? If you do tract cautery, how do you do tract cautery? Do you like to cauterize the whole length of your tract, or do you just pull it back to the edge of the liver and then cauterize right there?
Yeah, I do use tract ablation or cautery. I will use it on pretty much every case. And the system that I use, we really just monitor the temperature in terms of the feed point. First of all, you have to know your device. So the feed point can be any amount of distance, actually, depending. So you have to know where that feed point is first. And then that feed point, I'll measure back to about 1 centimeter before the capsule. So in certain cases that are close to the capsule, obviously you don't need to track ablate. But if you're deeper within the tissue to your target tumor, then those types of cases, I will track ablate. And I figure, why not, right? You have the technology, you're there. It could potentially minimize the hemorrhage risk. And at the end of the day, it's just like a bovie, right? The technology, you're just heating up the tissue and cauterizing it. And so we'll measure from the feed point to about 1 centimeter before the capsule, because 1 centimeter before the capsule, there shouldn't be any big kind of structures like portal vein, artery significant in that way. And then the cautery should sufficiently, cauterize that tissue. And so we go to about there and then turn it off and then pull everything out.
Yeah, that's a great point. And, I think along those lines, I think a lot, there's some people that may worry about cauterizing so peripherally and having a thermal injury to the body wall, something along those lines. But it's such a short period of time, right? That I've never seen something like that happen. I don't know if you have or not.
No, I have not. It usually takes about a second or two for the temperature to go above 50, because your resting body temperature is right around there. You just have to be cognizant of where that feed point is. If you let it sit in the capsule or in, God forbid, the muscle, then yeah, the patient's going to feel it. But, I tell my patients, my residents, et cetera, that inside your body, it's really from stretching that causes pain and nerve fibers to trigger. So as long as you're not causing, inflammatory change near the capsule, patient's going to be fine.
Yeah, great point. Well, what about things like biopsy with ablation? When you're biopsying at the same time or using a coaxial system, do you like to go side by side? How do you approach that?
So early in my career, when we still have, I would say 10-15% of our cases, we're doing a biopsy and ablate because the imaging findings aren't specific for diagnosing or the history doesn't give us that. Early on in my career, I would try and, get fancy and do a coaxial type of system and all that stuff. And it was just much more hassle than I had wanted. And so I changed to trying having things parallel. But if you're going after a small lesion, let's say 1.5, 2 centimeters in size, the parallel, inevitably, you almost miss the lesion every single time. And I would, when I see patients in consultation, as well as the referring physician, tell them, listen, the ablation here, I feel, is more important than the biopsy. And 99% of the time, they're like, yeah, we agree. The ablation is more important. So that means that the biopsy may not yield significant tissue because my priority is to get the ablation probe in position first, and then second, to put my biopsy needle. So when I was doing it parallel, it was very tough. So now, if possible, I try and take more of a tangential approach where it may be like anywhere from 30 to 90 degree angle. But I always place my ablation needle first, and then I'll place and attempt my biopsy afterwards. Now that has its issues, and you need, I think, certain types of software if you can't see your tumor well, because again, that streak artifact happens. And if you can't see it under ultrasound, then you're going to have to triangulate and pinpoint with your biopsy needle.
Yeah, that is very challenging. I agree. And also just finding a coaxial needle that fits both the biopsy device and the probe, depending on what system you're using. That's also a challenge, right? So, but great point on the tangential approach. In my practice, I tend to go coaxial a little bit more, but having the approach to do tangential and target from different aspects in the liver is very valuable. So I'm glad you brought that up.
Yeah, and I will say, like, a good sign is when you're pushing your needle to get some tissue and then you're hitting your ablation probe. I always tell my fellows it's a good thing. Our biopsy, we always use a coaxial system. And so we've, a little medical fun here is we always kind of have fun when we place that biopsy needle, and then we'll turn on our ablation device. And from the biopsy, you'll see it was bleeding previously, especially a vascular tumor. And then as the ablation is going, you start to see kind of the blood coagulate through that coaxial needle, and then you'll get like a foie gras type of smell. Your hand.
That's a great point. I didn't think about that. Great point. I've never tried that. I'm going to have to try that. Also, and this goes back to what you mentioned earlier as well. There is a little bit of that tactile feedback. So sometimes, right, you can, as you deploy your cutting surface to the lesion, sometimes you'll feel that kind of pop through or the different tissue architecture or stiffness from the lesion to the normal liver parenchyma. So we're running out of time here a little bit. I got a few more questions for you. What about patients that have multiple small lesions? This can be primary HCC or oligometastatic disease, and then also patients that are oligoprogressive on immunotherapy. How do you approach patients like that? Will you try to clear the liver, analogous to the clock trial? Again, that was colorectal focused. Will you mix and match the right therapy or the particular therapy for a specific lesion?
So in terms, that's a lot of questions to cover. I'll try and tackle all of them. I will say that in terms of, let's say, HCC, and there are several lesions, from a logistical standpoint, we try and tackle multiple lesions with Y90, just because I think it's faster to treat those lesions in one setting. But if we can't, then all the lesions need to be under 3 centimeters in size. And we'll probably cap it at about 3 because, and it should be in a lobar. And it's what the intent of the procedure is. We'll definitely do that to bridge the patient to transplant if there are no other alternatives, such as radioembolization or TACE. Maybe the patient has undergone multiple transarterial therapies, including chemoembolization, and there's no further route of administering transarterial therapy. Then we'll flip to ablation in that setting. And we'll push it to try and get the patient to transplant as a bridging therapy if they have a realistic shot at transplantation. In the setting of oligometastatic disease, whether it's HCC or metastatic disease, It depends on really the multidisciplinary discussion. Maybe for metastatic disease, they've exhausted 2 lines of chemotherapy, whatever it may be. They still have intact performance status and underlying liver function is good. It's not a salvage type of setting. And there's maybe 1 or 2 lesions that are progressing despite therapy. I think it's reasonable to try and treat those individuals with that. There's also the type of setting I think that you're alluding to where, let's say they've had a large tumor, metastatic disease, and there was like 6 or 7 centimeters in size. They've responded, but now it's at like a 2 centimeter, 3 centimeter size. But there's still probably some activity there because we know a lot of chemotherapies, let's say outside of checkpoint inhibitors, is more of a tumor static. It has a response, but it doesn't have a complete response according to RECIST criteria. That's when we use consolidative therapy. And for that 2-3 centimeter size, even up to 4, we'll push ablation in that type of setting or another local regional therapy to consolidate in the hopes that there isn't micromets outside of that primary lesion. And I think ablation is extremely effective in that type of setting because at the end of the day, we're just depositing energy to burn the tissue. And hopefully in the process of burning and the margins, et cetera, we're consolidating and just destroying tissue. But, I would say first and foremost, it really does depend on a multidisciplinary setting. And that doesn't mean that, let's say, one subspecialty is dictating how the care goes. I think it's a discussion and also an awareness on the interventional radiologists to let other specialties know what we are capable of. And so it really does warrant a discussion like, hey, I see in tumor board, you have this patient who had a phenomenal response to your chemo, but there's still 2 centimeters left, or they underwent this and there's a residual tissue left. Hey, you know that an ablation in this setting is quite easy for me. It's a single session. And for instance, in our practice, an outpatient therapy, so the patient can go home the same day. So unless you let your referring physicians know that, they won't know. They won't know what you're capable of.
Yeah, that's a great point. I mean, and that just hits on the fact that, we need to be at every tumor board, right? Every multidisciplinary meeting and having that kind of seat at the table and that voice at the table and being able to articulate not just what the data says, as you already mentioned, but what we can actually offer in some of these situations from an outside the box plan. So that's a great point. So Ed, one last question for you. So, there's a lot of new technology that's coming into the space, right? There's new devices like HistoSonics, the Edison, I believe, galvanized Alea, IRE has been in the space for a little bit. There's new technology like robots for needle placement. There's augmented reality software platforms, right? There's so many new things that are coming into the space. Where do you feel like the space is going to go? Is there anything that you feel a device or a technology or software standpoint that is coming into the space that really revolutionize what we're doing? Or is there something that is really missing that we should be looking at?
First and foremost, I think there's a lot of excitement about new devices coming to market. To be quite honest, I don't consider IRE a new device, right? It's been around for 20 years. So it is what it is. But HistoSonics is a new player. Galvanize is a new player. But you have to see what those devices are created for. And I think it's certainly intriguing tech. And then there's, like you said, there's technology that's coming out to augment what we're already doing. Like you said, AR, VR technology, real-time visualization. For instance, like I had mentioned previously, Varian with their thermocouples kind of sets it apart from other ablation devices. I think ablation devices at the end of the day are a commodity. The technology hasn't changed. You're depositing energy, heating up tissue. What's going to set them apart are things like thermocouples and things like ablation, confirmatory software, planning software. I think will set apart because the technology hasn't changed with an ablation or radiofrequency ablation for years and years and years. So I can't imagine something coming out that will drastically change the field. I think in terms of other devices that are not necessarily ablation, depositing ultrasound waveforms, et cetera, that could be a game changer, but it has its limitations as well, right? It's an ultrasound-based technology. And so anything that impedes that, bone, air, limits applicability of that device. But maybe in areas that are not great for ablation or Y90, Now you have another tool in the armament. And I think that's ultimately great for patients. But I think the future is also we get more curative in terms of our intent. The data is coming out in terms of curative intent procedures rivaling surgical resection. But the other aspect is we can also potentially cause an immunomodulatory effect. And I think right now we're kind of living in this boom of checkpoint inhibitors. But for instance, let's look at the HCC space. Checkpoint inhibitors, the objective response is limited anywhere between 30 to 35% approximately. And if you look at the data in terms of the kind of miraculous complete responders, it's hovering around 7 to 9%. So can our local regional therapy technology in whatever form augment that? I think is the future, because checkpoint inhibitors make sense. Your own immune system attacking something that is foreign that shouldn't be there, such as a tumor. Can we achieve it across multiple disease states, a true type of cure in synergy with local regional therapies disrupting the tumor microenvironment? And in the colorectal space, there hasn't been a positive checkpoint inhibitor study yet. So can we take such a common kind of cancer within the United States and augment the ability of checkpoint inhibitors? Is it ablation? Is it Y90? Is it, ultrasound-based technology? Is it something else? We don't know, but unless we invest in that type of research, we won't know for sure.
Yeah, that's a great point. I mean, you're right. I don't think we know yet. There's a lot that's still coming into the fold as some of these technologies really mature and evolve over time. And so it's an exciting time to be in IR, to be in IO. And it'll be really exciting to see what happens in the next 5 to 10 to 15 years, right? So, well, Ed, that's all I had. I'll open the floor to you. Any further comments about ablation in the liver? Anything else that you want to mention?
No, I think the field has been quite steady. And I think with studies like Acclaim coming out, with newer technologies in terms of augmenting now the software ablation and potential real-time monitoring of ablation, I think it's quite exciting. Otherwise, it's been quite stagnant for many years. But I think potentially the synergy that happens between like imaging company and a device like Siemens and Varian could potentially push it to the next level.
Yeah, that's a great point. And I know the IntelliBlade system is out. I don't know when their software, the device ablation confirmation software program, the My Ablation Guide, I believe it's called, is coming out. So I guess more to come there as well.
Thanks, Kavi. Thanks for having me on the podcast.
Yeah, it was a pleasure. Thanks for sharing all your insights. It was a fantastic conversation and discussion. Thanks so much, Ed.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Aaron Fritz, and co-hosts
Chris Beck,
Sabine Dawn,
Michael Barraza,
and Ali Behetti.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles, Josh McWhirter,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang, Manisha Naganathanahali,
and Manbir Singh Sandhu.
Administrative support provided by Judy Dela Cruz.
Thanks again for listening.